First of all, thank you, and I'll keep it quick. Everybody's hungry and tired. But thank you, Dr. Rowland, first of all, for engaging the EDS issue into this MIND conference. So I want to thank you very much. Everybody just give an applause in this room. Tireless work. He would be paging and texting me at midnight, and all his folks. Anyhow, I'll be very brief and very quick about the spinal issues. As you've learned all day, this is not just about spine. This group of disorders involves several organ systems. I got involved in spine care of these patients, not because I invited them to my clinic, and I regretted it 5 years later. They're tough because I realized they have a lot of other issues going on. So basically, the main problem that in terms of spine that these hypermobile patients is obvious, right? Is the hypermobility in their spine. Their ligaments are loose, and so the most mobile part of the spine is your back, but even more mobile is the head, right? You're doing all this, right? And that can go out of whack if you've got lax ligaments, which is what EDS is, one of the things that it does. And so you can get instability. I hate that word. Let's just call it hypermobility, because a lot of people are quite hypermobile and no symptoms. So craniovertebral or spinal hypermobility is one of the important things that happens. But we have to remember that when the joint between the head and the neck or the joints in your cervical spine are hypermobile, the only thing that has to bear the weight, how many people know what this weighs? My patients know. 18 to 25 pounds. Now that's balancing a bowling ball on 2 fingers. How many of you can do that? You can't even do it. So what holds the head to the neck are ligaments and muscles. But if your ligaments are loose rubber bands, till Ann helps me fix this, it's your mast cells, my friend, and the immune system, how it just interacts with this collagen. The only thing left is the muscles. Now, what do overworked muscles feel like? Painful, right? If I told every one of you to run a mile right now, you'd be all coming in groaning, right? Some of you would collapse within 100 feet. I would collapse in about 50 feet because never mind. But I don't exercise much. But anyway, so that's a big problem. But the even bigger problem is that hypermobility creates a strain and a stress on what's inside the spine, right? And in the craniocervical junction is the brainstem, the medulla. So and remember, the spinal cord and the medulla doesn't like to be twisted, compressed, or bent. When you take a nerve and you go to the lab, I've done experiments in my youth, in the last century, where if you stretch a nerve, or you bend it or twist it, it stops conducting. It doesn't work right. So that's why the dynamic imaging is important, the prior speaker. We need to see how much that's. So Fraser Henderson was a geek like me in residency, and he studied what's called with finite limit analysis, which is what engineers use to figure out what kind of metal to put on an airplane. What are the stressors, right? So you can do finite limit analysis. It's coming to your theater soon. Where's Victoria? We will try to look at what is this bend doing to the stretch within the nervous system, right? When you're hypermobile. And because there are a lot of people you saw her images already, where they're bending the medulla, but they're fine. How you doing? I'm doing great. Well, we really need to figure out what that hypermobility is doing to the nervous system, whether it's in the cervical spine or the craniovertebral. Wow, I'm giving this talk without a slide. That's amazing. All right. The second problem in EDS patients is in their lower spine. Now, this is the enigma that the Norris Lab, where's the Norris Lab, folks? You're going to have to sort this out. And we are already doing it. That's called tethered cord syndrome. Now, if you talk to any neurosurgeon about tethered cord, they're thinking about type 1 tethering. Type 1 tethering is something you're congenitally born with. Things like myelomeningocele and spina bifida and a low-lying spinal cord. But type 2 tethering, which was first written about by Shoke Yamada, who used to be a faculty here and then went to San Diego. He's now passed away. He talked about how the phylum, so everybody here know what the phylum is? No. Again, hand waving here. When you're an embryo, When you're in the embryonic stage, the whole spinal cord, I'm going to demonstrate, is laying right in your butt. In the first 2 trimesters, the spinal cord's there, fixed at that end and fixed at that end, so that the nervous system can build neurons to the entire body, right? You need to hold the spinal cord still. After the 2nd trimester, when the baby starts growing, right, those connections are made, all right? And after you're born, you spring, you grow. Your spine, shell that contains the spine, is growing fast, but the spinal cord does not grow. So guess what happens? That attachment, called the phylum, remains, and your spinal cord starts ascending in your spine, right? Now, what do you think the elasticity of a normal phylum should be? Like a loose rubber band. Like a loose, and you're thinking, well, wait a minute now. EDS people are loosey-goosey? No. In EDS, the phylum turns into a guitar string. It turns tight, so it starts pulling on the spinal cord, tugging on it. Now, when you look at an MRI, 95% of the time, you cannot see the phylum. On the MRI, it just looks like a nerve among all those string of nerves in your spinal canal, in the lumbar spine. 5% of the time, you can see a fat phylum, or you can see a thick phylum, but most of the time you can't. That's type 2 tethering. So it's a clinical diagnosis. We'll figure it out. So lots of questions to answer about this. These patients with tethered cord syndrome, they have EDS. You shake their hand, and within 10 seconds, you go, oh boy. And then you ask them, and they say, I have back pain, and they're 19. You're 19 and you have back pain? They have pain in their legs. But the most important key thing is urinary. Do you have urinary symptoms? No. Wait a minute. Don't just say no. Do you have hesitancy? When you feel like peeing, does it take a second to think about getting going? Are you pressing? Are you bending over? Do you have urgency? You hardly got any urine in your bladder and you have urgency. Wrong messages sent to the brain that you need to pee. So frequency, urgency, hesitancy, urinary retention, right? The conus, which is the tip end of the spinal cord, controls all that. Now, if that part of the conus is being tugged by the phylum, it's not going to work right. Remember what I said? You can't tug on it, you can't kink the spinal cord, you can't twist the nervous system. So this is a clinical diagnosis. It's well established among those of us who have taken interest in tethered cord syndromes in EDS patients. So what do you do there? Cut the bloody phylum. You don't need it. You need it in your first 2 trimesters of life. You don't need that phylum anymore. So that's the second problem, tethered cord syndrome. Now, we're desperate to figure out a couple of things. One is, how do you diagnose this beyond clinical, right? Sometimes it's the physical therapist. Susan Chile will call me. I got this patient, we're doing pelvic therapy, they're just not tolerating. They walk out unhappier than when they came in because all her maneuvers, all the therapist maneuvers are not working. And then you sit and you ask them and you talk to them, and yeah, they've got tethered cord symptoms. And so you take that, you do a lumbar spine MRI, just make sure there's nothing else going on, right? 1 out of 20 times, you might see something. But, oh, we got pictures now. So those are the 2 things. Now, some of the symptoms are common to both tethered cord and cervical instability. They will have neurologic symptoms in their arms. They'll have neurologic symptoms in their legs, or they're unstable up here. They've got tethered cord for sure. What do you do first? In my earlier years, I used to just fuse them all, but that didn't work out very well for over half the patients because their tethered cord got worse. So now it's flipped for me in my practice. I've now done over 300 cord untethering on EDS patients, and that's worked out better because 30% of these patients that are untethered, these symptoms go away because now the spinal cord is floating freely. It doesn't matter how much it's stretched or pulled while they're in instability. And then, my God, the most important person in the care of an EDS patient, other than Anne and my GI colleague here, and everybody else, is the physical therapist. Because remember, I just said to you that training their muscles, training their brain on how to control those muscles around a hyperflexible or hypermobile spine is the most important thing. I've learned a lot. 3 different folks that taught me about the spinal issues in EDS. The first group of people are my patients. I began this journey 15 years ago. They've taught me a lot. They're all bright patients, ignored, but they do their homework and they come to me. I used to hate Dr. Google, who never went to medical school, but I love Dr. EDS patients. They teach me a lot. The second group of patients that have taught me are the peers, my physical therapists, my colleagues like Ann Maitland, my new colleague here at MUSC, Dr. Mohal Sharma, and a number of people we want to hire around us who are experts in genetics and everything else to teach me. And the third group of people, most important, are the people who are going to unravel the mysteries of the genetics, and that is the Norris Lab. So with that, thank you very much.